Okay, let's unpack this. Imagine you're a nurse, and you see this lab result pop up. A leukemia patient has a platelet count of 19,000 millimeter 3. What's your immediate priority? Like, what do you do right then?
That's a fantastic question to kick things off. Really highlights the kind of vital, practical knowledge we're getting into today.
Yes, right out of our source material. And it hits hard. We'll definitely circle back to the answer and exactly why it's so critical.
And why it matters so much. Because that single number points straight to a huge risk.
Bleeding, right.
Exactly. Serious bleeding potential. It really frames what we're tackling in this deep dive.
Absolutely. And today we're diving deep into oncological and hematological disorders. We're leaning heavily on a great resource, the Saunders Comprehensive Review for the NCLEX-PN Examination, 7th edition.
Think of this as us pulling out the absolute must-knows about cancer and related blood issues, making the complex stuff, well, hopefully a bit more straightforward for you.
Right. Our mission here is pretty clear. Extract the crucial bits, the descriptions, how things are classified, the risks, the tests, treatments, and maybe most importantly,
the nursing considerations, what you actually do. We want to make it understandable, relevant, and practical.
All right, let's lay the groundwork. Cancer itself. What are we actually talking about?
Okay, so at its most basic, cancer is what's called a malignant neoplastic disorder.
Break that down for us.
Sure. Malignant basically means it's harmful, it can invade tissues and spread. Neoplastic just refers to new, abnormal tissue growth. So put it together. Cancer is when cells lose their normal controls and just grow wildly.
Uncontrolled growth.
Precisely. And this can happen pretty much anywhere in the body. The impact really depends on where it starts and what kind of cells are involved.
And it's not just a localized issue, is it? Cancer can have effects pretty much everywhere.
That's a key point. It often leads to really serious systemic issues, meaning affecting the whole body. Like, it can mess with your hematopoietic function.
That's the blood cell production in the bone marrow.
You got it. Which then hits your immune system's ability to fight things off. It can also cause major problems in the GI tract, digestion, nutrition, all that.
And I see motor and sensory deficits mentioned too.
Oh, yes, those can happen. Plus, decreased respiratory function is another big potential impact. These widespread effects really show how cancer can disrupt, well, everything.
Now, the thing most people probably think of with cancer is its ability to spread. Metastasis. Let's talk about that.
Right, metastasis. It's the process where cancer cells break off from the original tumor, the primary site, and travel elsewhere in the body to start new tumors.
How does that happen? What are the routes?
There are basically three main ways. Understanding these is key for predicting where cancer might go. It guides treatment and surveillance.
Okay, what's the first route?
First is local seeding. Think of it like seeds falling off a plant and growing right next to it. The cancer cells spread into the tissues immediately around the tumor.
Got it. And the second?
Second, and this is the most common way, is blood-borne metastasis. Cancer cells get into the bloodstream.
And then they can go anywhere the blood goes.
Pretty much. They circulate and can eventually settle down and start growing in distant organs.
And the third pathway?
That's lymphatic spread. The lymphatic system, it's that network of vessels carrying lymph fluid, fighting infection. Cancer cells can invade these vessels.
And travel to lymph nodes.
Exactly, those little glands. And from the lymph nodes, they can potentially spread even further. Cancers starting in areas with lots of lymph vessels might spread this way earlier.
Makes sense. So how do we generally group or classify all these different cancers?
Broadly speaking, we put them into two main buckets. First, you have solid tumors.
Like breast cancer or lung cancer, associated with an organ.
Precisely. They start in specific organs or tissues. Breast, lung, colon, those are typical examples.
And the second big category?
That would be the hematologic cancers. These guys originate in the blood-forming tissues, mostly the bone marrow and the lymphatic system.
So that's where leukemias and lymphomas fit in.
Exactly. Leukemias affect the blood cells, lymphomas affect the lymph system, and you also have things like multiple myeloma, which is a cancer of plasma cells in the bone marrow.
Okay, so once a cancer is diagnosed, doctors talk about grading and staging. What's the purpose there? How does that help?
Right, grading and staging are super important. They help us describe the tumor in detail. It's not just about size, but how abnormal the cells look, how much it's grown, if it's hit nearby lymph nodes or spread far away.
So it guides treatment and gives an idea of the outlook.
Absolutely. It's critical for planning the best treatment strategy and understanding the likely prognosis. These systems give a really comprehensive picture.
What's the actual difference between grading and staging then?
Good question. Grading focuses on the cancer cells themselves under a microscope. It tells us how different they look compared to normal cells.
So how abnormal or aggressive they seem.
Exactly. It gives an idea of how fast the tumor might grow and spread. Usually graded I to IV, higher grades are generally more aggressive.
And staging, that's more about how far it's spread physically.
Yes, staging looks at the clinical picture, the extent of the cancer in the body at diagnosis. Size of the primary tumor, lymph node involvement, distant metastasis. That's staging.
Also usually numbers like 0 to pi v.
Typically, yes. Higher stages mean more advanced disease. Our source material actually has a good breakdown of these systems in box 41-2.
Let's shift gears a bit. What actually causes cancer? Or rather, what increases the risk? It's usually not just one thing, is it?
No, it's complex. There are quite a few factors that can increase someone's risk. We can kind of group them. First up, environmental factors.
Like chemicals, smoking.
Definitely. Chemical carcinogens are a big one, industrial stuff, certain drugs, and absolutely tobacco. Then you have physical factors like radiation X-rays, UV from the sun, or tanning beds. Even chronic irritation or trauma over time can play a role sometimes.
What about infections, viruses?
Good point. Certain viruses, called oncoviruses, are linked to specific cancers. Think Epstein-Barr virus and some lymphomas, hepatitis B and liver cancer, and HPV human papillomavirus, which is a major cause of cervical cancer.
TB, right?
And there's also a link between Helicobacter pylori, that's stomach bacteria, and gastric cancer risk.
Are lifestyle factors like diet involved too?
Yes, obesity is a factor, and diet. Well, there's ongoing research, but things like preservatives, contaminants, additives, nitrates in some foods are often mentioned as potential contributors.
And genetics. Does it run in families?
It certainly can. Some people inherit specific gene mutations that make them more susceptible. You might see certain cancers cluster in families. Chromosomal issues can also play a part.
Age seems like a big one too.
It is. Unfortunately, just getting older is a significant risk factor for many cancers. And finally, immune function matters.
Yes.
People with weakened immune systems may be due to AIDS, or because they're taking immunosuppressants after an organ transplant, they have a higher incidence of certain cancers.
So knowing all that, what can people actually do to lower their risk?
Prevention really boils down to avoiding known carcinogens where possible. Quitting smoking is huge. Limiting sun exposure, using protection, being careful with workplace chemical exposure.
And lifestyle changes.
Definitely. Maintaining a healthy weight, eating a balanced diet, getting regular exercise, these things can make a real difference.
Early detection is obviously key as well. What are the main methods we should know about? The source mentions box 41-3 and the text.
Absolutely critical. Early detection saves lives. Key screening includes things like mammograms for breast cancer, Pap tests for cervical cancer, various colorectal cancer screenings like stool tests and colonoscopies.
Prostate screening too?
Yes, PSA tests and digital rectal exams in some cases. Plus, encouraging self-exams is important. Breast self-exam, BSE, testicular self-exam, TSE, and regular skin checks. Just being aware of your body.
And that CAUTION acronym is helpful for general warning signs, isn't it?
It really is. CAUTION. Change in bowel bladder habits, a sore that doesn't heal, unusual bleeding discharge, thickening lump, indigestion, difficulty swallowing, obvious change in wart mole, nagging cough, hoarseness. Good things to keep in mind.
Okay, moving on. How do we actually confirm a cancer diagnosis? Let's talk tests.
Right, diagnostics. Which tests get used really depends on where the cancer is suspected, the primary site, or potential metastatic spots. And a crucial point, any invasive procedure needs informed consent.
Like biopsies.
Exactly. Biopsies, bone marrow exams. The patient has to understand the risks and benefits. Box 41-4 in the source lists a whole range of potential tests. X-rays, CT scans, MRI, blood tests like CBC and liver function, tumor markers.
But the biopsy is kind of the gold standard for diagnosis, isn't it?
It absolutely is. Definitive diagnosis usually comes from a biopsy. That's when a small tissue sample is taken from the suspicious area.
And examined under a microscope.
Exactly. A pathologist looks for cancer cells and determines the type. It gives that crucial histological evidence.
Are there different ways to get that tissue sample?
Yes, several types of biopsy. Needle biopsy or aspiration uses a thin needle. Incisional biopsy takes a small wedge of a larger tumor. Excisional biopsy removes the whole suspicious lesion if it's small enough. And staging biopsies might involve samples from multiple areas to see how far it spread.
What happens to the tissue in the lab?
It gets processed and examined. Two main ways: frozen section or permanent paraffin section.
What's the difference?
Frozen section is fast minutes. They freeze the tissue, slice it thin, get a quick preliminary look, often done during surgery to help guide the operation.
And permanent section.
Takes longer, maybe 24 hours. The tissue is processed with chemicals, embedded in wax, allowing for really thin, high-quality slides, gives a much more detailed and accurate diagnosis.
What's the nurse's role when a patient is having a biopsy?
It's key, often done outpatient. Nurses help prepare the patient, explain the procedure, answer questions, relay any specific instructions. Afterwards, they give post-procedure care, infosite care, what symptoms to report, and critically, verifying that informed consent is signed and documented before the procedure starts.
Cancer often means pain. Let's tackle pain control.
A hugely important topic. First principle. Pain is subjective. It's whatever the person says it is. We absolutely must avoid under-medicating.
What actually causes cancer pain? It seems like it could be many things.
It really can. Direct tumor pressure on nerves or organs, bone destruction, blockages, nerve compression or damage, tissue infiltration, inflammation, tissue death. Even psychological factors like fear and anxiety play a big role.
Distress screening tools can help assess that emotional component.
Yes, they can be very useful. Recognizing that link between distress and pain perception is important.
So how do we manage it effectively? What are the strategies?
It needs a team approach: doctors, nurses, pharmacists. The plan has to be individualized. Oral meds are usually preferred if possible, convenient, effective. Transdermal patches are another good option for continuous relief.
What about different pain levels?
For mild to moderate pain, things like aspirin, acetaminophen, NSAIDs might work. Severe pain often needs opioids. Codeine, morphine, methadone, hydromorphone are common examples.
And nerve pain, neuropathic pain.
That often needs different approaches: anticonvulsants, certain antidepressants, sometimes opioids too. For really tough pain, you might see subcutaneous or IV opioid infusions. Equianalgesic charts help us switch meds or routes safely.
What's the nurse's specific role in pain management?
Nurses are right there on the front line, constantly assessing pain, checking if meds are working, watching for side effects like sedation or respiratory depression, monitoring vital signs. It's crucial to report inadequate relief or concerns to the RN or provider promptly.
And non-drug approaches.
Also vital. Nurses use distraction, relaxation techniques, guided imagery, biofeedback, massage, heat or cold therapy. Even things like aromatherapy can help complement the medications and improve comfort.
Okay, let's talk treatments. Surgery is a big one.
Yes, surgery is used a lot in cancer care for diagnosis, staging, and obviously treatment. Sometimes it's the main treatment, sometimes it's combined with chemo or radiation.
What are the different reasons for doing surgery in cancer?
Several types. Prophylactic surgery removes tissue at risk of becoming cancer, maybe in someone with a strong family history or precancerous changes. Curative surgery aims to remove all the cancer, visible and microscopic.
What if you can't remove it all?
Then you might have control surgery, also called cytoreductive or debulking. The goal is to remove as much tumor as possible to make other treatments like chemo more effective.
And palliative surgery.
That's focused purely on improving quality of life, relieving pain, fixing obstructions, like in the airway or GI tract, reducing pressure on the brain or spine, stopping bleeding, removing infected tumors. It's not aiming for cure, but comfort.
Finally, reconstruction.
Right. Reconstructive or rehabilitative surgery helps restore function or appearance after cancer treatment, like breast reconstruction after mastectomy.
Surgery isn't without risks, though. What are potential downsides?
True. Adverse effects can include loss of a body part or loss of function, scarring, disfigurement, which can lead to body image issues and grief. And then there are the general surgical risks: pain, infection, bleeding, and blood clots, thromboembolism.
Let's move to another major treatment. Chemotherapy. How does it work?
Chemotherapy uses powerful drugs to kill or stop the growth of cancer cells, those neoplastic cells that divide rapidly. The catch is, these drugs aren't perfectly targeted.
They affect healthy cells, too.
Unfortunately, yes. Especially normal cells that also divide quickly. Think skin cells, hair follicles, the lining of your gut. sperm-producing cells, and crucially, the hematopoietic cells in the bone marrow that make blood cells.
Which explains a lot of the common side effects.
Exactly. And chemo is usually systemic, meaning the drugs travel throughout the whole body, typically given IV or orally.
Is it usually just one drug?
Often, it's combination therapy using several different chemo drugs together. The idea is to get a better response and try to design the regimen so the toxicities don't overlap too badly. And the naders.
Naders. That's when blood counts are lowest.
Right. You try to plan combinations so the lowest points for blood counts from different drugs don't hit all at the same time, if possible.
So what are those common side effects we should anticipate?
The big ones include fatigue, often significant fatigue, hair loss, or alopecia, nausea, and vomiting, mucositis.
That's the mouth sores and sore throat.
Yes, inflammation of the lining of the mouth and digestive tract. Also skin changes like rashes or dryness. And myelosuppression, that suppression of bone marrow we mentioned.
Leading to low white cells, red cells, and platelets.
Correct. Neutropenia, low infection-fighting neutrophils. Anemia, low red cells causing fatigue. And thrombocytopenia, low platelets increasing bleeding risk. Our source notes, Chapter 42, goes into much more detail on managing chemo side effects, which is huge for nursing.
Okay, next step, radiation therapy. How does this one fight cancer?
Radiation uses high-energy rays or particles like X-rays to damage the DNA of cancer cells, which ultimately kills them. The goal is always to zap the cancer cells while sparing the surrounding normal tissue as much as possible.
Is it more localized than chemo?
Generally, yes. It's most effective for treating cancers confined to a specific area.
What about side effects from radiation?
They tend to be more localized, too, depending on where you're aiming the radiation. Common ones include skin changes and irritation in the treatment area, hair loss only in the treatment field, and fatigue that's a very common systemic side effect. Altered taste can also happen.
The source mentions two main types, external beam and brachytherapy. What's the difference?
External beam, or teletherapy, uses a machine outside the body to direct radiation beams at the tumor. With this type, the patient is not radioactive. Skincare in the treated area is really important, though box 41-5 has specific instructions.
Gentle washing, no rubbing, avoid sun and heat.
Exactly. Soft clothing, nothing tight or binding.
And brachytherapy.
That's internal radiation. The radioactive source is placed inside the body, either right in the tumor or very close to it.
So with brachytherapy, the patient is emitting radiation.
Yes, for the duration the source is active. This means they can be a radiation hazard to others, and precautions are needed.
And brachytherapy itself has two forms, unsealed and sealed sources.
Correct. An unsealed source is usually a liquid radioactive substance given orally, IV, or instilled into a cavity. Because it's not sealed, it gets into body fluids, meaning the patient's excreta, urine, feces, sweat will be radioactive for a time, usually around 48 hours, until the body eliminates most of it. Special handling precautions are needed for that period.
Okay, and a sealed source.
That's different. The radioactive material is sealed inside something solid, like tiny seeds, wires, or pellets. These are implanted directly into or near the tumor. They can be temporary or permanent.
Does the patient emit radiation with a sealed source?
Yes. While the implant is in place and active, the patient emits radiation. However, because the source is sealed, their body fluids and excreta are not radioactive.
Box 41-6 talks about priority actions if a sealed implant gets dislodged. That sounds serious.
It absolutely is. If an implant falls out, the #1 rule is do not touch it directly.
What should be done?
Keep everyone away. Use long-handled forceps, never bare hands to pick it up carefully. Place it immediately into a designated lead-lined container. Then notify the RN and the radiation oncologist right away and document everything meticulously.
What about after a temporary sealed implant is removed? Is the patient still radioactive?
No. Once the temporary source is out, the patient is no longer radioactive. It's important to reassure them of that and that their cancer isn't contagious.
Any specific follow-up advice?
Yes, they'll get instructions, especially if it was a cervical or vaginal implant, about resuming intercourse. And they need to know what symptoms to report, things like severe diarrhea, urinary issues lasting over 24 hours, blood in urine, heavy vaginal bleeding, extreme fatigue, bad abdominal pain, fever, or signs of infection.
Let's move to bone marrow transplantation, BMT, and peripheral blood stem cell transplantation, PBSCT. These sound complex.
They are complex, but can be life-saving. Basically, BMT and PBSCT replace stem cells that have been destroyed by high-dose chemo or radiation.
Stem cells being the mother cells for blood production.
Yeah, exactly. These immature cells in the bone marrow create all our blood cells. Transplants are often used for leukemias, lymphomas, multiple myeloma, some other cancers too.
Why are they needed?
Right.
Because the cancer treatment is so harsh?
Precisely. The goal is to wipe out the cancer cells with really high doses of treatment. But those doses also wipe out the patient's own bone marrow. Without a transplant, the patient wouldn't survive because they couldn't make blood cells leading to fatal infection or bleeding.
So the transplant rescues the marrow function. Where do the healthy stem cells come from?
3 main sources. Allogeneic means from a donor, usually a matched sibling, parent, or an unrelated donor found through a registry. Syngeneic is from an identical twin, a perfect match, but rare.
And the most common type.
Autologous. That's using the patient's own stem cells. They're harvested earlier, usually when the patient is in remission, frozen, and then given back after the high-dose treatment.
Can you walk us through the basic steps of the transplant process?
Sure. First is the harvest collecting the stem cells. For PBSCT, it's from the bloodstream using apheresis, like a specialized blood donation via a central line. For BMT, it's usually multiple aspirations from the hip bones under anesthesia.
Is this done before the intense treatment?
Yes. If it's autologous, the cells are often treated to remove any stray cancer cells, then frozen, cryopreservation. Allogeneic cells are usually infused fresh. This harvest happens before the next step, conditioning.
Conditioning, what's that?
That's the high-dose chemo, sometimes with total body radiation. It has 3 goals: kill any remaining cancer cells, suppress the patient's immune system so it doesn't reject the donor cells if allogeneic, and make space in the bone marrow for the new cells to grow. It's a very tough phase for the patient.
Then comes the actual transplant.
Yes. After conditioning, the harvested stem cells are infused through the central line, similar to a blood transfusion. It usually takes a few hours.
And the final crucial step is engraftment.
Exactly. Engraftment is when the transplanted stem cells find their way to the bone marrow, start multiplying, and begin producing new, healthy blood cells. Success is marked by rising blood counts, white cells, red cells, platelets.
How long does that take?
Usually about 2 to 5 weeks, but it varies. Until engraftment happens, the patient is extremely vulnerable.
Why?
Yeah.
What are the big risks post-transplants?
Infection and bleeding are major concerns until engraftment. The patient essentially has no functioning immune system or ability to clot normally during that time.
Are there other potential complications?
Yes, unfortunately. Failure to engraft is when the new cells just don't take hold. That's usually fatal unless another transplant works. With allogeneic transplants, there's graft versus host disease, or GVHD.
What's GVHD?
That's when the donor's immune cells see the recipient's body as foreign and attack it. Skin, liver, gut are common targets. It requires careful management with immunosuppressants.
Anything else?
Hepatic veno-occlusive disease, or VOD. It's a blockage of small veins in the liver. Signs include right upper quadrant pain, jaundice, ascites, weight gain, enlarged liver. Early detection is key because there's no real reversal treatment, just supportive care.
Okay, let's dive into some specific cancers now, starting with leukemia.
Leukemia refers to a group of cancers starting in the bone marrow. The hallmark is an abnormal overproduction of immature white blood cells called blasts.
And these blasts crowd out the normal cells.
Exactly. They overwhelm the marrow so it can't produce enough normal red cells, normal white cells, or platelets.
How are leukemias classified? I see lymphocytic versus myelosic and acute versus chronic in the source, box 41-7.
Right. Lymphocytic means it starts in the lymphoid cell line, myelocytic or myelogenous in the myeloid line. Acute leukemia comes on suddenly and progresses fast, while chronic leukemia develops more slowly.
So the impact is anemia, infection risk, bleeding risk.
Precisely. Anemia from lack of red cells, leukopenia, and decreased immunity from lack of normal white cells, and thrombocytopenia from lack of platelets. The cause isn't always clear, likely genetic damage to cells. Risks include genetics, viruses, immune issues, radiation, chemicals, even prior chemo.
What signs and symptoms might point towards leukemia during data collection?
It can be quite varied. Things like unexplained anorexia, fatigue, weakness, weight loss are common. Anemia signs like pallor, shortness of breath on exertion. Bleeding signs, easy bruising, ecchymosis, tiny red spots, petechiae, nose bleeds, prolonged bleeding from cuts.
Fever, enlarged nodes or spleen.
Yes, elevated temperature, enlarged lymph nodes, spleen or liver can occur. Palpitations, tachycardia, orthostatic hypotension too, maybe headache, bone pain, joint swelling. Blood tests show variable WBCs, but usually low HGB, HCT, and platelets, but the definitive diagnosis.
Bone marrow biopsy showing blasts.
Exactly, that confirms it.
Infection seems like a massive risk.
Huge. Patients are vulnerable to infections from their own body's bacteria, auto-contamination, and from outside sources, cross-contamination. The risk skyrockets during the nadir, the lowest point for blood counts after chemo. Common infection sites are skin, respiratory tract, GI tract.
So nursing interventions are critical here. What are the priorities for infection prevention?
Meticulous hand washing by everyone is number one. Protective isolation might be needed. Strict aseptic technique for all procedures. Private room, maybe with special air filtration. Reducing environmental bugs, low bacteria diet, no fresh flowers, plants, no standing water.
Daily cleaning, good hygiene.
Absolutely. Antimicrobial soap baths. Frequent oral care box 41-8 details this. Inspect daily, soft brush, proper rinses, avoid harsh products, bowel program to prevent constipation, avoid invasive procedures if possible, daily dressing changes, wound inspection, monitor everything, urine, skin, mucous membranes.
Respiratory care too.
Encourage cough, deep breathing, check lung sounds, monitor vitals constantly, report any sign of infection immediately, fever, chills, redness, be ready for cultures, chest x-ray orders, administer antibiotics, antifungals, antivirals as prescribed, and crucial home care teaching.
Avoid crowds, infections, raw foods, standing water, litter boxes, live vaccines.
All of that. Infection is a major killer in immunosuppressed patients. We have to be incredibly vigilant.
Bleeding is the other big danger, especially with low platelets.
Definitely. Risk goes way up below 50,000 platelets. Spontaneous bleeding risk below 20,000. That often triggers a platelet transfusion. Packed red cells might be needed for anemia, too.
So, nursing actions for bleeding prevention.
Constant monitoring labs, checking for any bleeding signs, visible or internal. Gentle handling, careful with BP cuffs. Watch for internal signs. Pain, rapid pulse, increased abdominal girth. Soft foods. Avoid injections if possible or hold pressure for a long time. Pad bed rails, no rectal temps, suppositories or enemas. Monitor menstrual flow, administer blood products safely.
And patient teaching for bleeding risk.
Soft toothbrush, no floss. Electric razor only. Avoid nose blowing. Avoid sharp objects, contact sports. Crucially, avoid NSAIDs and aspirin. They interfere with platelets.
Fatigue and nutrition are bound to be issues too.
Absolutely. Profound fatigue from anemia and the disease itself. Need a balanced, high-calorie, high-protein, high-carb diet. Small, frequent, easy-to-chew meals often work best. Assist with care, balance rest and activity. Schedule things for when energy is highest. Blood products help anemia fatigue.
What other interventions are typical for leukemia?
Chemo is central induction, consolidation, maybe maintenance phases. Antibiotics, antivirals, antifungals.
Okay.
Colony-stimulating factors to boost blood counts. Blood product support. Infection bleeding precautions always. BMT-PB, SCT for some. Plus home care instructions and psychosocial support.
Okay, let's shift to lymphomas, starting with Hodgkin's disease.
Right, Hodgkin's lymphoma. It's a cancer starting in the lymph system, usually in a single node or chain. It tends to spread predictably to adjacent lymph structures, then maybe to organs like the spleen or bone marrow. The key diagnostic feature is finding Reed-Sternberg cells in a lymph node biopsy.
Causes, risk factors.
Exact cause is unclear, but links to viruses like Epstein-Barr exist. An important point. Surviving Hodgkin's treated with chemo increases risk for later cancers like leukemia or non-Hodgkin's lymphoma. Prognosis depends heavily on the stage at diagnosis.
What are the common signs and symptoms to look for?
Often systemic B symptoms, fever, night sweats, significant weight loss, also malaise, fatigue, weakness, anemia, low platelets can occur. The main sign is enlarged, usually painless lymph nodes, often in the neck first. Spleen and liver might be enlarged too. Diagnosis needs that positive biopsy with Reed-Sternberg cells, and CT scans help stage the disease extent.
How is Hodgkin's usually treated?
Depends on the stage. Early stages, 3 without bulky mediastinal disease, might get extensive external radiation. More advanced stages usually get combination chemo plus radiation.
Nursing focus during treatment.
Monitoring for side effects of chemo and radiation. Watching for infection and bleeding, using precautions if needed. And a really important discussion, especially for younger patients, is about the risk of sterility from treatment offering options like sperm banking beforehand.
Now let's cover multiple myeloma.
Multiple myeloma is a cancer of the plasma cells in the bone marrow. These malignant plasma cells multiply, form tumors in bone, and invade other tissues.
What do these abnormal plasma cells do?
They produce excessive amounts of a single abnormal antibody called M protein. A specific type, Bence Jones protein, often spills into the urine. This crowds out normal antibody production, leading to increased infection risk.
And it affects bones and kidneys.
Yes. The myeloma cells destroy bone, leading to pain and high risk of pathological fractures. They also cause high levels of calcium and uric acid in the blood, which can damage the kidneys, sometimes leading to kidney failure. It usually develops slowly, cause is unknown.
What are the key findings in data collection for myeloma?
Bone pain is very common. Pelvis, spine, ribs, weakness, fatigue, recurrent infections, anemia. That Bence Jones protein in urine, elevated serum protein. Osteoporosis, those pathological fractures are a huge risk. Need skeletal support during movement, safe environment. Thrombocytopenia, leukemia, high calcium, high uric acid. Kidney failure signs, sometimes spinal cord compression. Diagnosis confirmed by finding abnormal plasma cells in bone marrow.
How is multiple myeloma managed?
Treatment involves chemo, often with other drugs like steroids or newer agents. Supportive care is critical, managing pain, preventing fractures, treating kidney issues, fighting infections, managing bleeding risk, neutropenic bleeding precautions if counts are low, monitor everything bleeding, infection, fracture signs. Encourage high fluid intake over 2 day to help flush calcium and uric acid, protect kidneys. Monitor kidney function closely.
Ambulation helps.
Yes, ambulation helps bones and kidneys if tolerated. 5E fluids, diuretics for high calcium, blood transfusions for anemia, pain meds pharm and non-pharm, antibiotics for infections, bisphosphonates to reduce bone damage, maybe local radiation for pain spots, and thorough home care education, especially infection signs.
Let's switch to solid tumors now. Testicular cancer.
Right. Testicular cancer starts in the testicles, usually from the germ cells that make sperm. It's most common in younger men, typically 15 to 40.
Risk factors.
Cause is unknown, but having an undescended testicle, cryptorchism, is a major risk factor. Genetics might play a role. It can spread through blood, to lungs, liver, bone, adrenals, or lymph, to retroperitoneal nodes in the abdomen.
Early detection is key here, right? Testicular self-exam.
Absolutely vital. Monthly TSE. Figure 41:1 shows how. Best after a warm shower. Gently feel each testicle, rolling it between thumb and fingers. Should feel firm, smooth, egg-like, no lumps. Check for any changes, report anything suspicious immediately.
What are the signs someone might notice?
Often starts as a painless lump or swelling in one testicle. Maybe a feeling of heaviness or dragging in the scrotum. Sometimes enlarged lymph nodes in the groin or abdominal masses if it's spread. Rarely gynecomastia, breast enlargement. Late signs could be backbone pain or respiratory symptoms from metastasis.
Treatment approaches.
Often chemo, radiation, and surgery. Surgery usually starts with removing the affected testicle unilateral orchiectomy for diagnosis and treatment. Sometimes a more radical orchiectomy, testes cord nodes, or retroperitoneal lymph node dissection is done for staging or debulking.
Important discussions around fertility.
Crucial. Need to discuss impact on reproduction, sexuality. Offer sperm banking before treatment starts. Discuss other options like donor insemination or adoption if fertility is affected.
Post-op care after orchiectomy.
Monitor for bleeding, infection, manage pain ice packs to scrotum first 48 hours, help swelling. Report chills, fever, increased pain, drainage. Avoid heavy lifting as advised. Reinforce monthly TSE on the remaining testicle. Sutures out in 7-10 days.
Next, let's cover cervical cancer.
Cervical cancer starts in the cervix, the lower part of the uterus. It can be pre-invasive just on the surface lining, like CIN stages in box 41-9, or invasive, spreading deeper. Metastasis is usually later, via lymph. It often develops slowly from precancerous changes called dysplasia.
What increases the risk? HPV seems central.
HPV infection, particularly high-risk types, is the main cause. HPV vaccination is highly effective prevention. Other risks. Smoking, active or passive, early sexual activity 17, multiple partners for the woman or her partners, and not getting regular screening like Pap tests. Regular screening dramatically reduces deaths by catching changes early.
What symptoms might appear?
Early stages often have none. Later, painless bleeding after intercourse or between periods, especially postmenopause. Foul smelling or blood-tinged discharge. Pelvic, back, leg, or groin pain. Maybe anorexia, weight loss. In advanced cases, urinopheces, leakage from vagina, painful urination, blood in urine, and of course an abnormal Pap test result.
Treatment options. Box 4110 lists several.
Yes, depends on stage. Non-surgical, chemo, cryosurgery, freezing, external or internal radiation, laser therapy, surgical, conservation, hysterectomy, or the very radical pelvic exoneration.
Tell us briefly about cryosurgery and laser.
Cryosurgery freezes the tissue, causing it to die off. No anesthesia needed, maybe cramping. Expect heavy watery discharge for weeks afterwards. Avoid intercourse tampons then. Laser therapy vaporizes tissue seen during colposcopy. Minimal bleeding, some discharge, takes 6-12 weeks to heal.
Inchronization.
Removes a cone-shaped piece of cervix. Can preserve fertility but needs long-term follow-up for new lesions. Risks include bleeding, infection, incompetent cervix leading to preterm labor later.
Hysterectomy.
Removal of the uterus, often done for microinvasive cancer if childbearing is complete, can be vaginal or abdominal. A radical hysterectomy takes out more uterus, cervix, upper vagina, nodes for more spread. Pelvic exenteration is for advanced recurrent disease.
Post-op care after hysterectomy.
Similar to other major abdominal surgery. Monitor vitals, encourage cough, deep breath, ambulation, anti-embolism stockings, track IO, catheter care, hydration, check bowel sounds, incision. Manage pain, restrictions. No tub baths, prolonged sitting, maybe stairs for about a month. No heavy lifting. Good nutrition for healing. No intercourse for 3-6 weeks usually. Watch for complications.
A key point for post-hysterectomy bleeding.
Yes, monitor vaginal bleeding. Saturating more than 1 pad per hour is excessive and needs immediate reporting to the RN provider.
Pelvic exenteration, box 4111. That's the very radical surgery.
Extremely radical. Reserved for recurrent pelvic cancers. Cervical, vaginal, rectal, with no spread outside the pelvis. Removes pretty much all pelvic organs, bladder, rectum, uterus, vagina, nodes. Requires urinary and/or fecal diversions, like an ileal conduit and colostomy. Post-op care is intense, focusing on vital signs, fluids, respiratory status, and meticulous stomach care and education. Huge psychosocial impact.
Let's move to ovarian cancer.
Ovarian cancer starts in the ovaries. It's known for being aggressive and spreading quickly, often silently. Metastasis happens through direct spread in the pelvis, lymphatics, or seeding within the abdomen.
Why is it often diagnosed late?
Because early symptoms are often vague or absent. That contributes to its higher mortality rate compared to other GYN cancers. Diagnosis usually requires exploratory surgery, laparotomy. Ultrasound might be used, but hasn't lowered mortality rates.
What symptoms might eventually show up?
Persistent abdominal bloating or discomfort, feeling full quickly, vague GI issues like gas or indigestion, maybe abnormal vaginal bleeding, less common, a palpable abdominal mass, elevated CA-125 blood test, though that's not specific just to ovarian cancer.
Typical treatments.
Usually surgery plus chemo. Surgery often involves removing the uterus, hysterectomy, both ovaries and tubes, bilateral salpingo oophorectomy, and the omentum, fatty apron in the abdomen. Chemo is given after surgery for almost all stages. Sometimes chemo is instilled directly into the abdomen, intraperitoneal. Radiation is less common, maybe for specific targets.
How about endometrial cancer or uterine cancer?
This one usually starts in the endometrium, the lining of the uterus. It's often slower growing and more common after menopause. It can spread locally to the cervixovaries via lymph to pelvic aortic nodes, via blood to lungs, liver, bone, or directly into the abdomen.
What increases the risk for endometrial cancer?
Using estrogen therapy without progesterone is a big one. Never having children, multiparity, polycystic ovary syndrome, PCOS, older age, late menopause, family history, uterine cancer or Lynch syndrome, obesity, high blood pressure, diabetes.
What's the most common sign?
Abnormal vaginal bleeding, especially any bleeding after menopause. That's the classic sign. Also, unusual vaginal discharge, watery or bloody. Later signs might include low back pelvic abdominal pain or an enlarged uterus on exam.
How is it treated?
Depends on stage grade. Non-surgical options include radiation, external or internal, chemo for advanced recurrent, and hormone therapy, like progestins or antiestrogens if the tumor is hormone receptor positive. But the main treatment is usually surgery, total abdominal hysterectomy and bilateral salpingo oophorectomy, TAH-BSO. Sometimes lymph nodes are removed too.
Okay, shifting to a very common one, breast cancer.
Breast cancer involves uncontrolled growth of cells in the breast tissue. It's called invasive when it breaks through the duct or lobule walls into surrounding tissue. It commonly spreads via lymph, especially to the axillary armpit nodes. Bloodborne spread often goes to bone, lungs, brain, or liver. Diagnosis is usually via needle biopsy or surgical removal and microscopic exam.
Key risk factors, age, family history.
Yes, increasing age and family history, especially first-degree relatives, are major. Also, early menarche, before 12, late menopause after 55, personal history of breast uterine ovarian cancer, never having kids or late first pregnancy, obesity, high-dose chest radiation exposure, and specific gene mutations like BRCA1 and BRCA2.
What signs might someone find? A lump.
A lump or mass is the most common sign, often found on self-exam or clinical exam, frequently in the upper outer quadrant, under the nipple, or in the axilla, often detected on mammogram first. Cancerous lumps are typically fixed, irregular, non-encapsulated, and often painless initially.
Other signs besides a lump.
Breast asymmetry, nipple retraction or discharge, bloody or clear. Skin changes like dimpling, retraction, ulceration, or that orange peel look, peau d'orange. Swollen axillary lymph nodes, arm swelling, lymphedema. Late signs relate to metastasis, bone pain, respiratory issues.
Breast self-exam, BSE, is emphasized. Figure 41-2 shows how.
Yes, monthly BSE is important. Best done 7-10 days after period starts, or same time each month if postmenopausal. Check visually in mirror, shape, size, skin, nickel changes, palpate and shower, using finger pads, and lying down, systematic palpation of entire breast and axilla. The goal is familiarity to detect changes. Report any changes promptly.
Treatments. Non-surgical and surgical, box 4112.
Non-surgical includes chemo, before or after surgery, radiation, often after lumpectomy or for chest wall, hormone therapy for estrogen progesterone receptor positive tumors, and targeted therapies like trastuzumab for HER2 positive cancers. Surgical options, box 4112, range from breast-conserving surgery, lumpectomy, often with radiation and node biopsy, to mastectomy. Simple removes breast tissue and nipple. Modified radical removes breast tissue, nipple, axillary nodes, but spares chest muscle. Breast reconstruction is also an option.
Post-mastectomy care is crucial. Box 4113 has details. What are key points?
Monitor vitals. Position semifowlers. Elevate affected arm on pillows to reduce swelling. Encourage cough, deep breath. Manage drains, like Jackson-Pratt figure 41-3. Monitor drainage. Check site for infection, bleeding, fluid collection, seroma. Assess circulation sensation in affected arm. Crucially, no IVs, injections, BPs, or blood. Draws on the affected side to prevent lymphedema.
Home care instructions from box 4113.
Avoid overuse of arm, keep elevated. Incision care. Encourage support groups. Remind about BSE on other breast. Protect affected arm from injury infection. Gloves for chores. No signs of inflammation infection to report.
Let's move to digestive system cancers. Esophageal cancer first.
Malignancy in the esophagus lining. Two main types. Squamous cell and adenocarcinoma, often linked to Barrett's esophagus from chronic reflux. Big risks. Smoking, heavy alcohol use, GERD, Barrett's, complications, trouble swallowing, dysphagia, painful swallowing, odynophagia, poor appetite. Goal is to control tumor, manage symptoms, maintain nutrition. Data collection looks for progressive dysphagia, odynophagia, chest epigastric pain. Nursing focuses on nutrition monitoring, dietary changes, soft liquid, prep for chemo, radiation, or surgery.
Gastric cancer or stomach cancer.
Malignant growth in the stomach lining can invade deeper and spread. H. pylori infection is a big suspect, along with diets high in smoked, salted, processed foods. Smoking, alcohol, nitrates, history of ulcers also risks. Complications: GI bleed, obstruction, metastasis, dumping syndrome post-surgery. Goal: remove tumors, support nutrition. Early symptoms are vague: indigestion, discomfort, early fullness. Later: weakness, weight loss, anorexia, nausea, vomiting, maybe bloody. Dysphagia, obstruction signs, anemia, palpable mass. Nursing: monitor vitals, H&H, give small bland meals, manage nausea, prep for chemoradiation surgery, box 4114, post-op gastric surgery. Monitor vitals, Fowler's position, pain nausea control, monitor NG tube, NPO initially then advanced, diet slowly, watch for hemorrhage, dumping syndrome, B12 deficiency.
Pancreatic cancer next. Sounds serious.
Very serious, often highly malignant, usually adenocarcinoma from duct cells. Growth spreads rapidly. Risks: age, diabetes, chronic alcohol use, pancreatitis history, smoking, high-fat diet, chemical exposure. Symptoms often appear late when it's advanced, contributing to poor prognosis. Diagnosis uses CT, MRI, ERCP, data collection, nausea, vomiting, jaundice, significant weight loss, clay-colored stools, glucose intolerance, diabetes, abdominal pain radiating to back. Interventions: radiation, chemo, sometimes surgery. Whipple procedure is common but major. Post-op care is complex, like pancreatitis care, especially monitoring blood glucose.
Lower down. Intestinal tumors, including colorectal cancer.
Malignancies in the bowel lining, sometimes arising from polyps. Colorectal cancer spreads by direct invasion, blood or lymph, often to liver, lungs. Complications: perforation, abscess, fistula, hemorrhage, obstruction risks. Age 50, polyposis syndromes, FAP, Lynch, personal family history of polyps cancer, inflammatory bowel disease, UC, Crohn's, history of other cancers, ovarian, breast, etc. Key sign: blood in stool, visible or occult. Symptoms vary by location. Right side may be diarrhea, left side may be constipation, ribbon stools, rectal may be alternating constipation, diarrhea, bleeding. Late signs: abdominal distension guarding, palpable mass, cachexia. Diagnosis: Colonoscopy is definitive, also barium enema, CT, sigmoidoscopy, general interventions, monitor for complications. Radiation may be used. Primary treatment is surgery. Bowel resection with lymph node removal, often requiring a colostomy or ileostomy.
Colostomy and ileostomy care is important.
Very. Pre-op, enter stomal therapist, consult for siting education, diet instructions, bowel prep, maybe antibiotics. Post-op colostomy. Keep stoma moist initially, apply pouch, monitor stoma color, should be reddish, pink, moist, dark, dusky is an emergency. Monitor function, stool consistency varies by location. Meticulous skin care. Post-op ileostomy, drainage starts dark green liquid, becomes yellowish liquid, high risk for dehydration, electrolyte imbalance due to liquid output.
Moving to the respiratory system. Lung cancer.
Malignant tumor in the bronchi or lung tissue. Lungs are also a common site for mets from other cancers. Primary types, small cell, SCLC, and non-small cell, NSCLC, squamous adeno large cell. Spreads directly or via lymph, main cause. Smoking. Also pollutants, diagnosis, CXR, CT, MRI, bronchoscopy, sputum cytology, data collection. Cough, wheezing, shortness of breath, hoarseness, bloody purulent sputum, chest pain, weight loss, weakness, abnormal breath sounds, interventions. Monitor vitals, respiratory status, oxygen, respiratory treatments, high-calorie protein diet, non-surgical, radiation, chemo, surgical laser, thoracentesis, pleurodesis, or reception, pneumonectomy, lobectomy, segmental. Pre-op teaching includes possibility of chest tubes, post-op monitor vitals, cardiac respiratory status, manage chest tubes, encourage shoulder ROM. Airway patency is always the priority.
Laryngeal cancer, voice box cancer.
Yes, tumor in the larynx tissue often looks like an ulcer. Spreads locally or via lymph. Diagnosis, laryngoscopy and biopsy. Risks, smoking, all forms, heavy alcohol, combo of both pollutants, prior neck radiation, data collection, persistent hoarseness or throat, painless neck lump, feeling of lump in throat, burning sensation, dysphagia, voice changes, shortness of breath stride or weakness, weight loss, bloody sputum, bad breath. Nursing, maintain patent airway, positioning, assessment, suctioning, nutritional support, treatments, radiation, chemosurgery, ranging from cord stripping to total laryngectomy with permanent stoma. Pre-op, teach about surgery, airway management, communication methods, especially post-total laryngectomy, suctioning, pain, nutrition. Post-op monitor vitals, airway, suction frequently, high Fowler's position, monitor venolaryngectomy, care, box 41 to 15, and speech rehab, box 41-16.
Prostate cancer now, common in men.
Slow-growing malignancy in the prostate gland below the bladder, very common 50. Spreads locally or metastasizes, often to pelvic spinal bones, lungs, liver, kidneys. Risks, age, heavy metal exposure, smoking, STI history. More common aggressive in African-American men, often asymptomatic early, later. Hard nodule on DRE, growth hematuria. Late signs, weight loss, urinary obstruction symptoms, hesitancy, weak stream, frequency, nocturia. Pain radiating down leg. PSA blood tests can be elevated, but not specific. Diagnosis by biopsy, non-surgical hormone therapy, androgen suppression, active surveillance, radiation external or brachytherapy, chemo for advanced palliative care, surgical, orchiectomy, remove testes, various prostatectomies, remove prostate, retropubic, perineal, suprapubic, TRP, cryosurgery.
Post-op care after prostatectomy, TRP and CBI in box 4117.
After TRP, watch for hemorrhage. TUR syndrome, fluid overload electrolyte imbalance. Continuous bladder irrigation, CBI, often used to prevent clots. Suprapubic, abdominal incision. Monitor incision and catheter, maybe CDI. Retropubic, lower abdominal incision. Less drainage, maybe CBI. Perineal, incision between scrotum-anus. Higher infection risk, temporary incontinence common. General post-op. Monitor vitals, urine output fluids, watch for bleeding clots, ambulate early, manage pain bladder spasms, catheter care, inform about potential erectile dysfunction, sterility.
Lastly, bladder cancer.
Starts in the bladder lining cells, often as a papilloma, wart-like growth that becomes malignant. Risk smoking, major venereal exposure, prior pelvic radiation, mets common to liver, bones, lungs. Classic first sign, painless hematuria, blood and urine. Other symptoms, frequency, urgency, dysuria. Diagnosis, bladder wash cytology, cystoscopy with biopsy. Treatments, radiation, maybe intracavitary, chemo, systemic or intravesical into bladder. Surgical, TUR or BT of inner. Partial cystectomy or radical cystectomy removes bladder nodes, prostate seminal vesicles in men, uterus ovaries part of vagina in women, requiring urinary diversion. Diversions include ileal conduit, box 4118, uses intestine segment to create stoma. Continent pouches, cock, Indiana box 4119, internal reservoir emptied via self-cath. Neobladder, new bladder from intestine connected to urethra, or other stomas, nephrostomy, ureterostomy, vesicostomy. Pre-op teaching about surgery, planned diversion. Post-op monitor urine output, stoma care, watch for infection peritonitis, extensive patient education on managing their diversion. Stoma color is critical. Dark dusky needs immediate reporting. Indicates poor blood supply.
The source also highlights critical oncological emergencies. Quick overview.
Yes, crucial to recognize. Sepsis stick, high infection clotting risk. Prevention to sepsis key. SI-ADH. Tumor makes ADH-like substance, causes fluid retention, low sodium. Treat with fluid restriction, maybe sodium increase. Spinal cord compression. Tumor invades spinal vertebrae, collapse, back pain, then neurodeficits. Treat with steroids, radiation to chemo, surgery, hypercalcemia, often from bone mets. Fatigue, confusion, cardiac issues. Treat with fluids, calcium-lowering meds, mobility. Superior vena cava SVC syndrome, SVC compressed by tumor, swelling head, neck, arms, dyspnea, life-threatening, treat with positioning, steroids, diuretics, radiation stent, tumor lysis syndrome, rapid cancer cell kill releases potassium uric acid, kidney injury, electrolyte chaos, treat with hydration, monitor labs, manage K plus uric acid, allopurinol, maybe dialysis. For all these, notify RN provider immediately.
Okay, let's circle back to that critical thinking question. Leukemia patient, platelet count 19,000. What should the nurse do?
Right. As detailed in the source, 19,000 is critically low, huge risk for spontaneous bleeding. The absolute immediate priority is to initiate bleeding precautions.
Like gentle handling, soft toothbrush, avoid injection.
Exactly. Minimize injury risk in every way. Avoid rectal procedures, sharp objects. Then, immediately notify the RN and the provider about this critical lab value, and perform a thorough assessment for any signs of bleeding, internal or external. Be ready for platelet transfusion orders.
Finally, the review questions at the chapter's end cover a lot of ground, reinforcing what we discussed.
They really do. Topics like preventing renal failure in myeloma, testicular cancer signs, lab findings in leukemia chemo, larynx to radiation side effects, radiation teaching points external versus internal, managing dislodged implants, pancytopenia care, SI-ADH and lung cancer, Hodgkin signs, ovarian cancer signs, mastectomy complications, prostatectomy discharge instructions, and low platelet interventions during chemo. It really drives home the breadth of knowledge needed.
So wrapping up this deep dive, we've covered a massive amount on oncological and hematological disorders, from definitions and classifications to risks, diagnostics, the whole spectrum of treatments, and vital nursing care. Early detection and understanding complications are just so key.
Absolutely. Nursing is central, focusing on safety, managing symptoms, educating patients and families every step of the way.
It really highlights the body's complexity, doesn't it? How cellular changes can ripple through everything.
It does, that delicate balance and how these conditions disrupt it. The interconnectedness is striking, how one problem triggers others. It makes you think, what other questions does this raise for you about the body's resilience, its vulnerabilities, when faced with these kinds of challenges?
A powerful thought to end on. Thank you for joining us for this very comprehensive deep dive into oncological and hematological nursing. We hope this exploration was valuable and encourage you to keep learning. This really concludes our detailed look at this essential chapter material.